Morton at the National Rural Health Resource Center and the Technical Assistance and Services Center, or Tasc, and I'm joined in the office with Kate Stenyum, Cami Norland, Nicole Clement, and Margot Kulseth. Thank you so much for joining us today on our rescheduled Task 90 webinar. Our topic for the day today is Hospital Consumer Assessment of Healthcare Providers and Systems, or Hcaps. Just to run through the agenda, and then I'll move into an update from Tasc. We'll have a brief update this morning, and then, this morning still. And then following that, Michelle Goodman and Mike McNeely are on the call from the Office of Rural Health Policy to provide critical access hospital regulatory changes and an update on that, and then an update from the Office of Rural Health Policy. Following that, Michelle Casey with the Rural Health Research Center at the University of Minnesota, one of the partners in the Flex monitoring team, will provide an overview of Hcaps research. And then Paul Moore with the Office of Rural Health Policy will talk about the importance and value of Hcaps and the MB QUIP project, the Medicare Beneficiary Quality Improvement Project. We'll then move into some sharing of stories about work that's being done in the fields about Hcaps. Shonda Schrader, who is the Critical Access Hospital Quality Network Coordinator with the Center for Rural Health at the University of North Dakota School of Medicine and their Flex program there, will provide information on Hcaps 101 from the perspective of a Flex program. And then Julie Bostad, who is the Director of Nursing at the Heart of America Medical Center, which is a critical access hospital in Rugby, North Dakota, will talk about the value of Hcaps from the perspective of a critical access hospital. And then we should have plenty of time to move into questions and facilitated dialogue among the participants that are on the call today. So with that, I think I'll move into just a brief update from Tasc. Hopefully you are all well aware that the Flex Conference is coming up shortly. It's going to be July 10th and 11th in Bethesda, Maryland. And our theme for this year's conference is Strength in Numbers. A reminder that the deadline for registration is June 25th. Registration is available online, but please do note that when you complete your registration online, you're solely registering for the conference. You're not reserving your hotel room. The conference registration website, though, does provide details about a phone number to call to secure your hotel reservation. So again, reservations are required for the conference by June 25th. Please do so if you haven't yet, and if you have any questions about registration, please contact Nicole, and we can help with that. Thank you to those that have agreed to present at the Flex Conference. We're really excited and think we're putting together a really great agenda. A reminder to those presenters to please send your presentations to Nicole by this Friday, June 15th. Last week, Terry and I drove down to the Twin Cities, Minneapolis, St. Paul, and held a summit meeting. We do that periodically in Tasc to gain some more information from some experts around particular topics. And this time our summit was on critical access hospital financial leadership. So we brought together a group of financial consultants, researchers, state Flex programs, CFOs, the Office of Rural Health Policy was represented, as well as the Rural Hospital Performance Improvement Project, or RHPI. And it was a 2-half-day meeting, and at the summit we talked about what are the financial indicators of success and distress at critical access hospitals, and had the group try to come to consensus about a group of statistical indicators. We moved into a discussion then about interventions that can be used within critical access hospitals, and identified ones that the group felt the strongest about as being the most prominent. And there will be a summary that will come out from this, but the intervention that was really highlighted as being the most prominent for interventions and successful outcomes was revenue cycle management, as well as financial and operational assessments as well. We talked about messages for the Flex programs and what they can do to increase their awareness about financial and operational improvement at critical access hospitals, and then how they can deliver that information to critical access hospitals. And then on the second day, we moved into a discussion about what critical access hospitals can do regarding the context that we're discussing, but also what they can do to prepare for healthcare reform and the environment in the next few years. It actually really talked about the beneficial status that critical access hospitals really have as they focus on primary care. So from the summit, there will be a summary that will be released in late June to early July. Additionally, as kind of a partner document, we're putting together a CH Finance 101 manual. And so that document will really provide definitions about sort of the nuts and bolts things about critical access hospital finances and some of the lingo and terms. And both of those articles or publications will have the audience of flex coordinators, critical access hospitals administrators.
Audio recording for this meeting has begun.
And critical access hospital boards in mind. And so they're not written to an audience that has an in-depth financial background, and so really they should be an educational and teaching tool. There will be a panel discussion at the Flex conference this year that will highlight the outcomes from the Financial Leadership Summit, and that will be kind of the springboard for us to launch all the materials that are produced from the summit. So look for more information to come on that. Next week, as a follow-up to this webinar, we'll be having an additional webinar entitled Moving Hcaps into Practice in Critical Access Hospitals. And that webinar will roll out the directory that Tasc has been compiling about the certified Hcaps vendors, as well as engage the audience into a facilitated discussion about the benefits and barriers to using Hcaps in critical access hospitals. So that webinar will be Wednesday, June 20th from 2 to 3 Central Time, and will also be recorded as well. A few other highlights from Tasc. Kate Senyum has been working on developing a quality matrix, so she's been seeking some input from some of the Flex program coordinators and has been working in conjunction with NOSOR on laying out a matrix that maps the various different national quality movements that are going on right now. And Margot has been assisting with that project as well. And so it should be hopefully a nice tool that will lay out all the different measures about quality within MBQIP, some of the national movement with Partnership for Patients, et cetera. Meaningful use as well, and hopefully it will be a great tool. It's being reviewed by the Office of Rural Health Policy and Flex Monitoring Team, and we look to roll that out to you as soon as possible. Tasc has also been working with the University of Southern Maine on an assessment of rural health clinics and their use of health information technology. We have a database assistant right now that is individually contacting the rural health clinics throughout the country to complete their contact information so that the sample survey or assessment can start to be rolled out electronically. So thank you to all those states that have sent in their information to us about your rural health clinics and their contact information. We greatly appreciate it, and we're working diligently to build a database of all 3,800 of these clinics. We also have some resources that will be coming up for you that we wanted to make sure you're aware of. The Tasc staff has been working to identify and review some of our existing resources to align with the non-competitive grant guidance this year that you all are working on your edits for right now or have already submitted to the Office of Rural Health Policy. So we're making sure that the resources that we have align with the objectives and the work that you're being asked to do. So look for some messages coming in the future from Tasc about new resources and their availability to you electronically. Additionally, we'll be working with the RHPI project as they are right now working on building some financial and community benefit tools and resources as well. So we'll be sharing those resources cross-programmatically as well, and we'll be broadcasting that to you via email and rural routes and other communication methods. So those are the brief updates that I had from Tasc. So I think we'll move into the updates now from RHP. And Michelle, are you on?
Hi, this is Michelle. Hopefully people can hear me.
Michelle.
Hi. I have a number of different things that I wanted to just let everybody know about. Nicole, if you could go to the next slide, please. Thank you. The first thing is I wanted to provide an update on the fiscal year 2013 proposed inpatient prospective payment system hospital rule that just was released on April 24th, and comments are due June 25th. Now this is mostly for your PPF hospitals, not for the critical access hospitals, but it did provide a number of changes or updates to those sole community hospitals and Medicare-dependent hospitals and to the quality improvement program that I know people are interested in as well, since those are some of our rural providers. Next slide, please. For the updates, the rule does provide a 2.1% update to all hospitals. That translates roughly to a 0.9% increase in payments for all different hospitals. Rural hospitals will see a decrease in payments on average for all rural hospitals at about 0.5%. The sole community hospitals and Medicare-dependent hospitals, you will see a lot lower, a lot higher negative impact. One of the reasons for the Medicare-dependent hospital impact being at such a low number, -7%, is because of the expiration of the Medicare-dependent hospital classification that is expiring at the end of this fiscal year. Next slide, please. There are some changes to the sole community hospital classifications regulations that CMS is proposing to make. They are saying that these are clarifications. Currently, for those of you that are interested in that may work with sole community hospitals, the classification for that remains in effect without the need for the hospital to reapprove yearly. The hospital, though, must notify their fiscal intermediary or their Medicare administrative contractors, their MACs, within 30 days if there is a change that occurs that could affect their classification as a sole community hospital. The regulations specify 5 different changes, and I've listed those on our slide, on the slide there. So if there's an opening of a new hospital in that hospital service area, if there is an increase in the number of beds, if the geographic classification changes, these are things that if there are changes to that for that sole community hospital, they would need to notify CMS. Next slide, please. So CMS says that existing regulations are only addressing a situation where a sole community hospital no longer meets requirements to be classified as a sole community hospital, but they don't explicitly address a situation where that hospital may never have met the requirements to be a sole community hospital in the first place, but was incorrectly classified as a sole community hospital. So CMS says that they are clarifying the regulations to state explicitly that if a determination is made subsequent to the classification that a hospital never did qualify as a sole community hospital, the withdrawal of that status would be made retroactively to revoke that status for the entire time that hospital was a sole community hospital. CMS did state in the regulation, in the proposed regulation, that they do believe that it's appropriate to propose to allow a hospital that notifies CMS that it actually didn't meet those requirements for sole community hospital classification to maintain that sole community hospital status until the date that it notified CMS. So in other words, if a hospital goes to CMS and says, we never actually met those requirements, they would revoke that to that date where the sole community hospital told CMS that they had an incorrect status. If CMS finds out that through audits or whatever, that hospital should never have been a sole community hospital, they can revoke that up to the time that it became the sole community hospital, so potentially much longer period of time. So this is something to think about. If you work with a lot of sole community hospitals, you might want to see if that's an issue for you, and you might want to let them know that this is a proposed clarification, and you may want to make comments to that regulation. Next slide, please. For those of you that work with Medicare-dependent hospitals, that, as I said, that is going to be expiring. That classification is expiring September 31st of 2012. CMS is proposing to allow a Medicare-dependent hospital to apply for sole community hospital classification as long as they put in that application 30 days prior to the expiration of the program, so by August 31st or September 1st, and request that that the sole community classification be effective with the expiration of the Medicare Dependent Hospital Program. So this is something that is a concession that CMS has made for those hospitals, those MDHs that are finding themselves in a position where if they can become a sole community hospital, this might be a good glide path from one designation to another. Next slide, please. Another thing that has been really beneficial for rural hospitals is changing with this. Beginning in FY 2013, the low-volume hospital qualifying criteria and payment adjustments will revert back to what they were pre the Affordable Care Act. So the Affordable Care Act made a couple of changes to this low-volume hospital payment adjustments. This is expiring as well, so the requirements for this will go back to what it was pre the signing of the ACA. So that would be that the hospital needs to be a subsection D hospital, which is otherwise known as a prospective payment system hospital, located no more than 25 miles from another subsection D hospital, and have less than 800 discharges during the fiscal year. So you might have some rural hospitals that, non-critical access hospitals that were receiving this low-volume payment adjustments that may not be getting that after October 1st. Next slide, please. Just a few quick updates on the Inpatient Quality Reporting Program. CMS is proposing some new measures for 2015 and 2016. If you can go to the next slide, please. For 2015, they are going to be removing about 17 different measures, from taking the total measures down from 72 to 59 measures that PPS hospitals will need to be reporting on. They are also proposing to adopt 5 different measures, 3 of which are claim-based. One is a chart abstracted, and another is a survey-based measure looking at care transitions. And I know you all will be talking about with the Hcap survey, so this might be something that comes up. And for 2016 payment determination, they are looking to propose 1 more structural measure. Next slide, please. Really briefly on the value-based purchasing program, this again does not affect critical access hospitals, but will affect those small rural PPS hospitals that you may be working with. They will be adding 4 new measures for the 2015 program and are removing 2 measures in the surgical care improvement project measures. And they are also looking at Medicare spending per beneficiary. They will be adding that as a measure. And they are looking at a minimum of 25 cases, but are seeking comments from people about whether to increase that minimum threshold to about 50 cases. And I know that's something that may or may not be an issue for some of the smaller PPS hospitals. Next slide, please. And then for 2016, the Vbp program, the value-based purchasing program, they're going to be maintaining the same measures that they have finalized in the 2014 and 15 program. Next slide, please. Now, I wanted to give some more information on the 3-day payment window, 72-hour rule. This is something that I know a few of you may have heard at the National Rural Health Association annual meeting. And this is one of the things that came up there, was that there was some confusion about how this works for those critical access hospitals that are wholly owned and operated by a prospective payment hospital. So if a patient receives outpatient services at a critical access hospital that is wholly owned and wholly operated by a PPS hospital, and that is then admitted to that inpatient PPS hospital, either on the same day or within 3 days immediately following the day of that outpatient service, then the 3-day payment rule will apply. There's a good chart on the next slide that might help clarify this And if you can go to the next slide, please. Or if you're already there, sorry. All right, there you go. So this chart just shows that if the CAH is wholly owned and operated by a non-CAH, then the window does apply. If the CAH is wholly owned and operated by another CAH and it goes from an outpatient to an inpatient, the payment window does not apply. And if it's a non-CAH that transfers, outpatient that transfers to a CAH inpatient, then the window does not apply. Hopefully this clarifies a little bit of the confusion that had come out of that meeting. Next slide, please. This is, I know, something that is near and dear to a lot of critical access hospital administrators and those that work with critical access hospitals. CMS did state last year that they would not be enforcing supervision requirements for the outpatient therapeutic services in CAHs and in small rural hospitals of less than 100 beds for calendar year 2012, so for this year. We're still waiting to see what they will do next year, and hopefully we'll be seeing the outpatient prospective payment system regulation that will provide further information on this in the next few weeks. CMS did put together an advisory panel on hospital outpatient payments that would work to evaluate appropriate physician supervision levels for those outpatient therapeutic services for a hospital and for a CAH. They would be providing recommendations semi-annually through a 30-day sub-regulatory public comment period. And then changes to the supervision levels can be made twice a year, in January and in July. Next slide, please. So CMS did make some decisions from the last meeting in February. This panel did meet. A hospital from, I believe, one of the southeastern states did provide around 20 or so different services that they thought needed to be moved from direct to supervision to general supervision, and most of those were psychotherapy services. And the panel did recommend all of these to be moved from direct supervision to general supervision, and CMS did finalize all of these different services. I provided a link in the on the slides that will take you to the decisions by CMS and give you the exact. It'll give you a list of all of the exact therapies that were moved from direct to general supervision. Next slide, please. And CMS will be holding its next semi-annual meeting of this advisory panel on August 27th and 29th. And I just would really recommend that you work with your critical access hospitals so that they know that this is something that they can actually send in or provide information to CMS of those services that they would want to be moved from direct supervision to general supervision. This is your time for those critical access hospitals and for the FLEX program to really maybe look at helping those critical access hospitals to put forward those services. There is a link there to the Federal Register notice that provides the exact directions on how to go about presenting at this meeting and what you need to do. And I would just really recommend people to look at that. We can only do so much. We are not necessarily the best people to say what are those services, those outpatient therapeutic services that should be moved from general to direct. The critical access hospitals and the small rural hospitals that are actually providing the care, the physicians there, the nurses, the PAs, they're the ones that are really going to know what should be moved from one service to another. And I think that is it. I've listed all of the names of the policy team, so if you have a question, you can reach out to any one of us, and we can get hopefully get your answers to your questions, or at least try to find the correct answer. And in the next slide there, or the last slide, you do have my contact information, and I'm always available. I check my email way too much, so if you have any questions, feel free to ask at that time. Are there any questions? I know I went fairly quickly, so I apologize.
Thank you very much, Michelle. That was a really wonderful overview of the critical access hospital regulatory changes. If there are not any questions, then I think we'll move on to Mike McNeely with the Office of Rural Health Policy Update.
Thank you. Just for reference, we did create a longer policy update this time around, so I just want to give a brief update so that we can stay on track for our Hcaps presentations. In general, there are two review cycles going on right now. Both SHIP and FLEX are under review when it comes to the non-competitive continuations. The FLEX, there have been a number of them that returned requesting additional information on their future work plans. This is not reflective of any of the work that the programs have been doing. It's more about trying to get a uniform view of what type of measures, what type of activities, what type of outcomes we want represented within the within your future work plans. I will say that a second review of those will occur starting on the from the 13th on, depending on your deadline, and we will also be providing feedback, effectively telling you where we think improvement may be required. For reference also, just know that these will not impact any of your programmatic funding levels. Everything is going forward as is, and what we are trying to do is just kind of mold the work plans for future usage. We've learned a lot from the first set of work plans that have come through, and we expect to learn a little bit more from the second go-round. We are going to try to provide, with the help of Tasc and some other resources, some materials to help this process become easier for next year, including a full template for the application for the next cycle. Other than that, that is the update from ORHP. If there are any questions, I would be glad to take them for the moment. Otherwise, it can be Michelle's presentation time.
Great. Thank you very much, Michelle. Moving on to Michelle Casey with the Rural Health Research Center of the University of Minnesota will be presenting on the overview of hospital consumer assessment of healthcare providers and systems research. Michelle?
Yep, I'm here. You're going to control the slides from your end?
You should have rights. I just gave them to you. However, there are two of you in the list for some reason. So in the lower left, there's arrows that point right and left. Why don't you try those and see if the right arrow is working for you? It may be the other you in the list. Okay, let me try that again. How about now?
I'm not seeing them.
The big screen, the big square that has your presentation in it, down in the lower corner of that, lower left, there's right and left arrow. There you go.
Okay. Did you do it from your end?
No, I didn't.
Oh, okay.
I can now.
All right, I must have done something. So, okay, so I was just going to talk about a couple of things. This is going to be very brief, but just a little bit about why Hcaps is important and what the research shows on it, how CMS has been using Hcaps, And then based on the work that the Flex monitoring team has been doing in terms of our national and state reports that we do every year, just a little bit about how critical access hospitals are reporting Hcaps data and the results of the Hcaps data, how do they compare to other hospitals. Okay. So why are patient perceptions of quality important, and why should we even be looking at Hcaps data? From the perspective of a patient-centered healthcare system, it's really important to ask patients what their perceptions are and not to, just make assumptions about them. So in and of itself, I think it's really important to look at the Hcaps as an opportunity to get information from patients about what they feel the quality of care they're receiving has been. But there's also a body of research that suggests that patient perceptions about quality influence a whole range of health-related behaviors from patients, everything from the health plans and providers that they choose, patient complaints and malpractice claims, how patients adhere to the medical advice they're given, and even, some indication that it can affect health and functional status outcomes. So that's one of the reasons why CMS was interested in terms of putting forth the Hcap survey as something that is important for hospitals to do. So they've said that they have 3 goals overall for Hcaps, providing comparable data on patients' perspective of care. Prior to Hcaps, a lot of hospitals were doing surveys of patient satisfaction, but there really wasn't one nationally accepted survey that would allow you to compare hospitals on an objective basis. CMS also wanted to create some incentives for hospitals to improve their quality of care and then to enhance public accountability through public reporting. So how have they been using Hcaps? Back in 2006, hospitals were given the option of voluntarily participating in Hcaps, and then starting with 2007, PPS hospitals are actually required to do it as part of their inpatient quality reporting and hospital compare. And now CMS, as part of the hospital value-based purchasing program for PPS hospitals, Hcaps actually comprises 30% of the total performance score for PPS hospitals, which is quite a significant amount, and I think an indication of how important CMS thinks this is. Now, clearly, the inpatient reporting and the value-based purchasing are not applying to critical access hospitals at this time. But the Affordable Care Act did charge CMS with implementing a demonstration program to look at value-based purchasing for critical access hospitals and other small volume hospitals in the future. So I think that it's an indication that Hcaps is important to CMS. They consider it part of a really important part of value-based purchasing, and I would not be at all surprised if it was a part of the demonstration that they would be looking at that for critical access hospitals and possibly down the road to having that be part of a value-based program that involved critical access hospitals. So just very quickly in terms of some of the research that we've done, this is actually a project we did as part of our research center. And back in 2006, we took the Hcaps data and we looked at the relationship between Hcap scores and the rurality of the hospital and some other hospital characteristics. And I put a link at the end of the slides for this report, so I'm not going to spend a lot of time on it, just to tell you that basically what we found were that rural hospitals, and that included critical access hospitals, had significantly higher Hcap scores than urban hospitals. And then when we looked at a lot of factors that we controlled for, in addition to looking at the rurality of the hospital, like hospital size and staffing, there were still significant differences, and that so there's something there beyond just the small size of the hospital, that patients in rural hospitals are scoring hospitals and higher on Hcaps, and that actually has been consistent, as you'll see when I talk about the work we've done as part of the Flex monitoring team. Those results with rural hospitals apply to critical access hospitals and have every year that we've looked at the Hcaps data. So just a little bit about Hcaps reporting by critical access hospitals. For 2010 discharges, which are the last full year that we have of the of data from Hospital Compare, 38% of the critical access hospitals reported Hcaps data, and most of the critical access hospitals that are doing Hcaps are doing that in addition to inpatient measures. A few are also doing outpatient. There's just a very small handful of hospitals that are only reporting Hcaps data. But the reporting for Hcaps, like the inpatient and outpatient data, does vary widely by state. We have one state that had no cause reporting and 2 states that had 100%. And the next slide is just a little bit difficult to see in terms of, because there's a lot of information on it. Not getting it to move down either. There it is. Okay. But this is all the flex states and the percentage of critical access hospitals that are in that state that are reporting Hcaps, and you can see, you know, the wide range. I think we put the national average in here, but yeah, the national average you can see of 38, and then the states that are above and below that. Okay. I just wanted to talk very briefly about Hcaps response rates. CMS recommends a response rate of at least 40%. So of all the eligible patients that are sent the survey, they'd like to have at least 40% respond them, because lower response rates, you know, are typically associated with having less representative data from the survey. And of the 505 CAUSE that did have Hcaps data for 2010, 1/3 of them had response rates of 40% or more. So that means 2/3 didn't. But if you look at the average rate for all hospitals in the country, and that's including critical access hospitals, but all other hospitals, the reporting rate was only 33%. So critical access hospitals, only 1/3 of them have that 40%, but the national reporting on response rates definitely could use some improvement as well. In terms of the completed surveys, CMS also recommends that each hospital obtain 300 completed surveys. And this is basically to ensure that there is adequate statistical power to compare hospitals to one another and to national benchmarks. And this has been an issue for some critical access hospitals, because even with, you know, all adult medical, surgical, OB patients, they may not get up to that 300 completed surveys. And CMS also decided that they would exclude patients who are discharged to swing beds, and that just happened last year, and that's also been an issue for critical access hospitals. So you can see the distribution here that, you know, actually the majority of critical access hospitals did have less than 300, but most were in that middle group. I think the concern is really in the lower group where you have less than 100 completed surveys. Okay, and then here's the results, and you can see across the board that critical access hospitals did have better scores on each of the Hcap measures than all U.S. hospitals. And this is basically the top category, which is usually the way CMS reports it. So it's the percent of patients who reported the highest level, you know, communicated well, yes, gave the higher ratings. And I think we can see, you know, here again that for critical access hospitals, Hcaps results are generally more positive than other hospitals, and so it's one area where critical access hospitals can do well in terms of the quality measures. And then the next slide, I just have a couple of resources in terms of the annual reports that we've done that have Hcaps for the state and national ones. If you want to look at them, they're all on the Flex Monitoring Team website. The study I mentioned that we had done as part of the research center, I put a link in there. And then if you're not as familiar in terms of the background of Hcaps, there's a link to a fact sheet that's really good explanation of kind of the basics of it, how CMS works with the data, and so I would recommend that as a real short, good overview of Hcaps. And that's it. Are there any questions?
Yes, Michelle, this is Cami Norland from the National Rural Health Resource Center. How often will the Flex Monitoring Team be monitoring the Hcaps data like this? The charts that you've provided have been really informative, and I like seeing the breakdown between critical access hospitals and non-critical access hospital percentages of where critical access hospitals are excelling. Is that something that's going to be maintained on a regular basis, or?
Well, we've been doing it on an annual basis, and part of the reason for that, you know, is if you take it quarterly, as with the other measures from Hospital Compare, the numbers are not necessarily up there for Hcaps for critical access hospitals. So we certainly plan to do it on an annual basis. And I guess the issue would be as far as when Hcaps becomes part of the next, you know, phases of MBQIP where Hcaps is in there. I think we'll have to kind of see how that works in terms of how often ORHP wants to look at that data, and, you know, if it'll need to be more often than annually.
Great. Thank you very much. Are there any other questions? It's *# to unmute your line.
Michelle?
Yes.
This is Kevin Driesen in Arizona, and I'm wondering, do you see a difference in the response rates for telephone versus mail? Is that something that makes much of a difference for critical access hospitals?
You know, we don't see that information. CMS does adjust the rates based on how the hospital administered the survey, if it was by mail or by phone or by, you know, a mixed mode. And they do all that before the data ever get posted, because they have done studies looking at the differences in terms of response rates. So once the data is public, it's been adjusted for that, and we don't see that information. But I do know from their studies that there are differences up front in terms of the kinds of response rates depending on how you administer the survey.
Great. Thank you very much, Michelle. And if you have any additional questions for her, please feel free to email her. Moving on to Paul Moore with the Office of Rural Health Policy in HRSA. Paul, could you please explain the importance and value of Hcap and how it relates to MBQIP?
Thank you very much. I look forward to the opportunity to do that. As I look at the participant list today, it's almost like a family reunion, and I realize that a lot of these folks listening on the webinar today, we've had a one-on-one talk about Hcaps, maybe a hand-holding talk about it, because we realize that there are issues in asking critical access hospitals to do something on a voluntary basis that they may or may not be convinced of the value in it. That's why I'm so looking forward to hearing from Shonda and then also from Julie today, because that's from the field. That's where it needs to come from, not from me. Just to summarize briefly, because I do want to move on to our next presenters, is to look back over MBQIP. Hcaps is just a part of it. It's just a part of the second phase of it. But what we're looking at to do with MBQIP, and I think that the speakers so far today have brought up some good issues why MBQIP exists. It's across all the states. We're so grateful now that we have over 1,000 critical access hospitals signed up for it. All but I think one state is on board, so a significant number of calls. We're looking at doing something with the data that you can't do through Hospital Compare. Just as I was listening in, it occurred to me to do a little bit of math. Michelle shared with us that 38% of critical access hospitals are reporting Hcaps, but that only about a fourth of those, 27%, have the threshold of 300 or greater. So what that boils down to, if you multiply 38 times 27, you realize that only about 10% of all critical access hospitals are getting their Hcaps information on the Hospital Compare website. That's why MBQIP has added it to our set of measures, is that if we're going to do it, we want to make sure you get credit for it, that it gets out there. Now, I totally agree with what Michelle said. If value-based purchasing comes our way in any form or fashion for critical access hospitals, I can promise you that patient satisfaction will be a key part of that. And like she said, with the PPS, it's 30% of the equation, so it'll be a big part of it. And I'll admit up front, as I've already admitted with many of you, there could be we could probably draw up a better survey for our critical access hospitals, one that was more meaningful in a smaller community where folks know each other on a first-name basis. But the fact is, if we get to the point where it's required as part of our reimbursement, this is the one that will count. And so that's the message you need to take forward to your hospitals as you visit with them about this, as you get some legitimate pushback on it as far as, well, why Hcaps and why that particular survey, we're doing better things. Like I said, it's part of Phase 2 that starts this fall. That's going to be on us quickly. And so what I want to encourage you, I want to stop and say thank you to the folks who have done such a yeoman's work of getting your hospitals engaged in MBQIP. Phase 1 was the easy lift. And you say, wait a minute, Paul, that MOU wasn't all that easy. But in all honesty, the MOU in Phase 1 was the easy part. That's why we started with it. It's going to get increasingly difficult as we move into Phase 2 and to Phase 3. So if you have not already really ramped up on the Phase 2 measures, getting folks ready for the outpatient measures and the Hcaps, then I encourage you make that a priority at this point. There's a quick look at the outpatient measures. You know, there are 23, I think, of them, but we're just picking the first 7. And once again, a good number of you have hospitals reporting on the outpatient measures, probably not as much as we see on the inpatient measures. So once again, a little heavier lift for you to get this in front of your hospitals and get them going with it. Not just signed up that they're going to do it and you expect they did it because they signed the MOU, but to follow back up with them and make sure they are ramping up, that if they're not doing it, they're learning, you know, how to use the CART tool on those measures. And then also there's the survey topics that go with the satisfaction survey, the different basic areas of questions. Michelle mentioned this, but I think this is something that we can't underplay, and that is the fact, because of the personal relationships we see so often in our critical access hospitals and for other reasons, including that we might just be trying harder, critical access hospitals are doing better on the Hcaps survey, so we might as well help them take advantage of that. if I can, that may be my last slide there. So I do look forward to hearing from the field. I will entertain some questions when we get to that, and plus every single one of you have my address, my email address, and my phone number. So as issues come up, just as the one Kevin just mentioned, the idea of which survey gets the best response, telephone or mail, we've had discussions with CMS, with the Arizona QIO, who's in charge of the Hcap program, and then also with the central office in Baltimore. And there are issues around the way the survey has to be presented. I think, Kevin, I do think I remember that they said that the telephone survey had a little bit higher response rate, but if I remember right, it wasn't all that significantly different. There's a lot of difference between Hcaps information or Hcaps data and Hcaps scores. Because once again, as Michelle shared on how that, if you don't have 300, you don't even make the scorecard, and then how that a lot of them have less than that. There are also other ways that the data is adjusted before it comes out as Hcap scores on the Hospital Compare website. What we're going to do with MBQIP is give you what you report. We're going to get this data back to you, and it's not going to be in a score form that's been pre-adjusted to where you don't even recognize your own data. It's going to be data, not scores, and it's going to give you a chance to really see where are places for improvement. Where can we get better at what we do? And so, having said that, give us a holler here at the office if there's other issues that come up, situations that we might be able to help you with. I encourage you, it's not too late to start, even for those hospitals that you have out there that have not signed up for MBQIP. You know, we're almost to the finish line. So if some of your hospitals are the ones that are still holding out, let me encourage you to go after them and get them. And thank you, Tracy, for the chance to visit with you today.
Thank you so much, Paul. We really appreciate it. Looking at the flex perspective, back at the National Rural Health Association conference in Denver, we held a small group meeting to learn more about the benefits and challenges of Hcaps, and Shonda Schroeder participated in that conversation and provided some very helpful insights and articulated herself quite well regarding the flex perspective. And so we thought we would feature some of the lessons that she had shared with us that day. Shonda Schroeder is a network coordinator for the Critical Access Hospital Quality Network for the Center of Rural Health at the University of North Dakota School of Medicine and Health Sciences, where she coordinates activities and provides technical assistance related to patient safety and quality improvement initiatives to rural hospitals. And she is also joined with Julie Bosted, who has worked for the Heart of America Medical Center in Rugby, North Dakota for 31 years. And during that time, she's held the positions of critical care coordinator, maternal child coordinator, assistant director of nursing of acute care. And for the last 18 years, she's been the director of nursing on acute care. And currently, she is the director of nursing. She also serves as quality manager and risk manager. So we have some real excellent expertise here on the call today. And with that, I'd like to turn things over to you, Shonda.
Thank you, and hopefully you can all hear me on the call. I don't see my slides up right now, so I'm not sure if they're going to be shared. Is everyone able to hear me all right? Do you have my slides to present, Nicole?
We can hear you okay. Nicole might have had to step away from her desk or something, so why don't you go ahead and just start, and we'll catch up to you when we can.
No problem. So what I'm going to share is just a little bit about how, from our flex perspective, we've moved, well, there we go, Hcaps in our North Dakota cause. So to start with, what we really have is a network approach, and I am located at the North Dakota Center for Rural Health, and it sort of helps to understand how we're structured so you can see why we were able to do a network approach. So From the Center of Rural Health, we have a lot of programs. We have our State Office of Rural Health. We have our FLEX program. We have AHEC. We have Workforce. But really, under the FLEX program, then, we support and fund the North Dakota Critical Access Hospital Quality Network. So this quality network is made up of all of the critical access hospitals in our state, which there are 36 critical access hospitals, and you can see them here on the map of the state along with their transfer patterns. But the mission of our network really is to support ongoing performance improvement of North Dakota's critical access hospitals. And that's been our mission since we began the network in 2008. And so I'm sure thanks to Paul and the others for sharing other information, but you can see how that really aligns well with the goals of MIBQIP and even with the purpose of Hcaps. So when this rolled out, I really thought that, there's going to be pushback, but this is going to be a topic that our critical access hospital should really, rally around and support, because it really is what we strive to do. So our network is led by an executive committee, which is made up of members from our critical access hospitals. So as a coordinator of activities through FLEX and through our network, I don't do anything unless I've approached our executive committee first, which has been really helpful in terms of MIBQIP and Hcaps, because I can go to this committee and say to them, here's the next step, what are your suggestions, and what's the best approach, and how can we make sure that everybody is really included in the discussion. So our first steps that we took was to roll out the MIBQIP MOU, which Paul says was the easy part, but I will say it did take a lot of work on our end. But I do see it being, easier than the next few phases. So we started by actually going out to all of our hospitals because it was clear they wanted to sit down and visit with us. So we sat down and we told them what MIBQIP was, what it would require, and on these visits we were also able to sort of assess what would be coming in phase 2. So we were able to say, are you already doing Hcaps? If so, who do you use? And if not, would you be willing to approach a vendor as a network to make it more affordable and to also have the opportunity to benchmark data and compare data across facilities? So these meetings are beneficial for the cause to learn more, but also beneficial for us to learn more as well and really create a strong plan of action. The biggest question was, what is the expense for our cause? So we called a lot of vendors and did sort of what they're preparing for all of you to roll out on the next call. We created a kind of a spreadsheet of the vendor, their services, their method or mode of research, and what their anticipated expense was. And so we did this and then began to educate. Now, educating our cause, we did this through a webinar. I educated on anything from the very basics of what Hcaps is, what this additional acronym in healthcare stands for, and how it related to MIBQIP, and basically told them, well, you already agreed to do this, so let's learn about it, because we do have 100% MIBQIP participation. And on this webinar, I also had Julie share as what I consider my cause spotlight, because she is one of the critical access hospitals in our state already collecting data with Hcap surveys and doing great things with it. So I had her share with this group too, because though I have a strong working relationship with most of them, they still want to hear from one of their partners or hear from somebody else that's like them. So it was really great to have Julie speak to why it's important to do Hcap surveys for a lot of the reasons that Paul articulated earlier. We also have a partnership through the North Dakota Hospital Association, and this partnership is to, first of all, make us stronger and reduce duplication, but it's also because as a FLEX program working through the North Dakota Center for Rural Health and under the medical school here at the University of North Dakota, we can't really get into vendor negotiations, and so the Hospital Association will do that on our behalf and on behalf of the cause. So the Hospital Association sent out a request for proposal from 8 vendors. Now these vendors were those that were already present in North Dakota, or else those who were suggested by other Midwest FLEX programs. So thank you to those of you on the call who maybe shared some of this information. But we just tried to figure out what else is already happening in our area that we could make sure that we can benchmark, I guess, with other areas and with causes that are like ours. So then we had a vendor work group, and that was also hosted through the Hospital Association. So then our role at the network is to review all the proposals that came in, develop cost comparisons, sort of create another spreadsheet, cheat sheet I would consider it, that compared all of those 7 vendors that sent in proposals so that our work group really had the information in front of them. Those in our cause that we were asking to participate in a work group, they don't have time to read through every proposal. They don't have time to think about what questions they should ask. So the more information we can present to them, the better. And then they can make an informed decision without having to read through the specifics of every single proposal. So we sent out all of that information, arranged the work group, and brought this work group together. The work group came together, and it consisted of critical access hospital DONs and CEOs, and it also had the CEO from Heart of America. So thanks to Julie, she had Jeff, which is their CEO, come and attend on her behalf, and he really brought a lot of experience and discussion because he was familiar with the preferred vendor of the group, and he was also currently collecting Hcaps data, so he was able to speak from a CEO perspective of why it's something you should continue to pay for as a facility. Why is it something that should continue to be an expense for your facility? Because how do you benefit from it? And so his voice was really strong for those at the work group. The work group did decide on a vendor, and this is where we feel like we're strong as a network because not only could we do a network approach to make it more affordable, but it was also an opportunity for us to let them make the decision. So we're not picking the vendor for them. We're just helping them through the process. And I think that's important because nobody knows what the facility needs more than those in the facility. We've just now contacted all of those 21 CAUs that are not yet doing the survey that would be part of this group and shared with them who was chosen as our vendor, what the services are that they offer, and they were given contracts to sign. So we're now working with the vendor on the next steps. We are discussing funding and how NDHA will make the payment. And I will mention here that it's our Flex program that's supporting the first year of Hcaps data collection for our cause. And so this is why there had to be a strong relationship with our hospital association so they could work out that payment with the vendor. We're serving as a resource to cause. I continue to educate. And moving forward, as the data begins to be collected and rolled out, I, as the coordinator for the network, will serve as the individual to help them look at the data and make sense of it and maybe even find regional activities to improve our numbers. And, you know, it's definitely on the forefront because we don't even have contracts signed, but then we'll have to help them plan for year 2 when it's no longer something or a fee that we will be covering. And I just wanted to say something that's important, I think, is that if you educate on the forefront and make sure they understand you've already signed to be a MIBQIP participant, which means you've already agreed to do this, that there really isn't as much pushback because when we began the work group discussion, they all began to talk about, well, what's the preferred vendor, what criteria do we need, and I realized nobody in this work group questioned whether or not we should move forward with Hcaps. And I felt like that was a testament to the work we've done on the front end because I was prepared for somebody to come to that meeting and say, okay, so why are we doing this again and why do we even need a vendor? And nobody did. So I felt like we had significant buy-in at that point. Finally, I just wanted to touch on, from these work groups and meetings, what barriers there were to moving forward with a network approach to Hcaps and what that work group had as considerations for their vendor. So on barriers, cost. I list that first, and I list it a lot because it always came back to whether or not this was affordable. And, you know, even when we say that we can assist with Flex, they immediately say, well, what about the year after? And obviously, from a Flex perspective, we're hoping that by then you see the value of it and it's not going to be something you want to cut. But at the same time, it has to be affordable. And so when we reviewed vendors, that was always the point that we came back to, was how much is this going to cost our facility? And very heavily related to cost is the issue of time. so this is where it became important to point out why you should have a vendor for this and not be doing it yourself, at least in our North Dakota cause, because there just isn't the time afforded to be doing their own surveying. And so when this was pointed out, it was a question for the vendor too. How much time will I need to submit reports and to give you patient lists? What's required on my end? And so after cost, you can see under the considerations, next was what's the time commitment. Another barrier is that a lot of the cause shared that, well, we already do a patient satisfaction survey. We don't need another one. We get the information we need from this survey. And that's when I really spoke to what Paul's already addressed as well, is that you can do that, but you can't benchmark. And so, there is always the fear of, well, it might be mandated soon, but that's the fear of everything for a cause. So I really try to reiterate the fact that this gives us the opportunity to benchmark. And our group already does an excellent job of that with a lot of other measures, even event reporting. So that was something that had significant buy-in, that, well, I can learn from this then, and I can compare this to other facilities. So when we present it as a learning opportunity and a stronger approach to improvement, there was a lot more satisfaction with the idea of doing this. Another barrier was they just weren't aware. I think when I first started speaking to this with our cause, I would say Hcaps, which is another acronym, and I'd sort of get a blank stare. So the webinar to even just educate on what an Hcap survey is and what it asks was really helpful, because it's not necessarily that our cause don't want to be doing more, but they might not even be aware of what's been going on. So it's important to, be the eyes for them and bring information to them. Another barrier was the purpose or the benefit, and that's really related to low volumes. And I think Paul did an excellent job of addressing that, and that's basically what we told our cause too, is that, this is going to benefit you, it's going to benefit the patient, and in the future it may benefit your bottom line. And so we really like to be an example and a step ahead in North Dakota, and I'm sure that's true across the board for everybody, but this was a chance to tell them that we can get a step ahead and we can be doing something that really will improve patient care and be forward-thinking. And in terms of low volumes, we address that with all sorts of data collection, and what we always say is that at the network, myself included, we can help you look at your own numbers. So it doesn't matter if you have low volumes and it's not going to go to hospital compare and that patients might not see it out on the front end. Because on the back end, we can see the data, we can compare it, we can benchmark it, and we can learn from it. So if it's still being able to be used for performance improvement, then that's what's important. And so that's how we were able to address that issue with our group. And in terms of consideration, it was cost. That was the primary consideration of who they chose as a vendor. And the time commitment, the vendor they chose had the method they preferred, which was to mail the survey. They didn't like the idea of the phone, from our group anyway. And the ease of use was really a selling point, in that a lot of the work was done for them by the vendor, and that was the main idea of cost as well, because it saves them time. They also wanted a vendor that had very specific experience, and so they actually asked vendors to speak to that on our work group call when we had demonstrations. Finally, there was the option of other surveys, and that's something Julie might speak to as well, but the idea that, well, maybe once we have our hands wrapped around Hcaps, we'll want to survey other things like employee satisfaction, and they wanted to make sure the vendor had capabilities to do that moving forward. And finally, they were just kind of interested in the reputation of the vendor, and they were able to hear this from a current CEO who had worked with this vendor while being a CEO in another state. So it really was a good testament to say, I know that they're present in the Midwest, I've worked with them before, and here's my experience. And even though I'm in North Dakota now, I still support this vendor. And so that's really been our perspective, and as a Flex coordinator, I just feel like if they've signed to participate in MIBQIP, it really just is, you've already signed, and we'd really like to move forward. And this is just another step and another way to improve your quality of care. And if you can get over the hurdle of cost, I think you can have very strong buy-in, because there is such benefit to the Hcap survey. So I guess I would like to turn to Julie now, if she'd like to speak to the next slides about her perspective as a CADON actually using the data.
Julie probably needs to unmute her line. Please press *# and you should be able to be heard.
Okay, hopefully you can hear me better now.
Yep, I hear you.
Okay, great. I've been asked to give you our experience with Hcaps, and so I'm going to go through our process a little bit, and hopefully you'll get some coaching tips out of all of this. And thank you again for inviting me to join your conference. First of all, excuse me? Is it okay?
Yep, go ahead.
All right. Just a little history. Heart of America has been doing Hcap service March of 2007. We were actually PPS at the time, and so it was mandatory, and then we did just choose to continue after we went critical access shortly after that. We initially only did inpatient Hcaps, and our cost was $2,900 a year. Since January of 2011, well, actually back to that $2,900, I believe that cost now is closer to $5,000 on this with our vendor. But since January of 2011 now, we have become a universal member with our vendor, NRC Picker. And that cost is actually $20,000 a year that we spend on employees or patient satisfaction surveys. With that universal membership, we get surveys for inpatient hospital, emergency room, clinic. We get 5 outpatient areas of our choice, and we chose outpatient surgery, lab, x-ray, PT, and then something we call group therapy, which is actually not where we send frustrated DONs, but it's actually RT and OT. And with this, we also get employee engagement surveys and also physician engagement surveys, which we have not done the physician survey yet. So just a little bit. So obviously, we have gone big into satisfaction surveys. As far as choosing a vendor, we really had no rhyme or reason why we picked NRC Picker at the time that we started doing Hcaps, except for the fact that Trinity Medical Center, our primary tertiary care center, also used NRC Picker, and it just made sense at the time to follow them. Since then, they have switched, and I really can't find out why. We have been fairly happy with NRC Picker, and except lately, we've had a few frustrating moments, but for the most part, they've been okay. I do think when you coach your cause on picking a vendor, there is some merit to a good vendor. They do really help us when you have problem areas and things like that, and I think it's worth coaching them not to just look at price. So as far as the survey process itself, and I don't know how familiar all of you are with this, so I hope I don't get too detailed or too elementary, but the process itself really takes almost no time with a vendor. If you tried to do these without a vendor, it would be very labor intensive, and it's highly regulated, and it's essentially impossible. But NRC Picker gave us the data set they needed for the surveys. Our electronic medical record, Healthland, set up a crystal report for us, and then essentially twice a month we run the report and export it to NRC Picker, who then sends out the surveys. We chose to use only mail surveys. Our vendor told us that they felt response rates are less with telephone. I don't know. I know that question was asked earlier. I don't know if that's true in all areas, but that was their recommendation to us. And the survey is also in different languages, which we generally are pretty much all English. The scores are compiled and reported quarterly, and the vendor will send the results to CMS and whoever else you want them to send them to. So hopefully, am I doing okay so far? Is this a good start? Or am I getting too detailed?
You're doing great. Thank you very much.
Okay, well, just let me know if I'm getting too detailed. As far as the surveys themselves, I'm guessing that most of you have seen a survey. One thing that I I would recommend with the inpatient Hcaps is there's two choices. You can do the regular survey, which is 22 questions and 5 questions about the patient, or you can do the extended survey, which is 45 questions. And we do the smaller one, and I guess I would recommend that just because of, I think most smaller communities have a high elderly population, and the other survey is just very, very long. The other thing that I think you should really stress about the surveys is the fact that you only get credit for the most positive answer. And so most of the questions have choices of always, usually, sometimes, and never, or something to that effect. And you only get credit for the always. So a usually and a never actually score the same on your Hcaps. So I think it's really important that we see that our CMS is looking for excellence and only excellence. And there is nothing, they will not accept anything else. And so as facilities, we should have that same mindset. So the time actually that is spent on Hcaps really is not in sending the surveys, it's taking action on the data that you receive. And by the same token, the value of the survey is dependent on the amount of time that you take. If you don't spend the time, it's just not worth the trouble. And we are a pretty good example of that, in that initially when we did only inpatient Hcaps, we had really high scores initially. And I hate to admit it over national WebEx, but we really took that for granted. We just kind of went through the actions. We did our reports, we took actions, posted information, but we didn't, I don't feel as we are now, we didn't embrace it, and we didn't probably embrace it as a team and as an entire facility. We had a lot of issues with our ancillary departments because I think you need to be sure and coach these CAHs or any of your hospitals that the patient sees everyone as a nurse. And so if those nurses did wonderfully well, and they may have picked an always, except, you know, the receptionist wasn't that nice and the lab girl wasn't that nice, so they're gonna give you a usually score. It tips the scale. And our ancillary departments didn't see really that their interaction with the patient really impacted the scores like it does. And so consequently, we've, you know, we didn't really look at the satisfaction as a journey so much as it was, you know, we thought, well, we're good and that's all we needed to know. So I have to say we failed a little bit as a facility in getting that across. And things changed. The bar is raised. Facilities across the nation are doing Hcaps and gearing in on patient satisfaction. And we need to realize that we always have to be improving. We can't just stop. So 5 years later and $17,000 later, we are looking closer and working much harder and focusing way more on our Hcap surveys. Now, I don't think you need to be doing all these surveys to get that effect, but I think that all hospitals really do need to be coached at paying closer attention to these questions and understanding them and focusing. So another change we made, and this probably, well, this was based a lot on our Hcaps and to continue to improve our Hcaps, is that we joined the Studer group. And basically, the Studer group has transformed our culture of our organization. So we are seeing a lot of action and commitment to these Hcaps, partially because of Studer. So we have got several committees, measurement teams, communication teams, rewards and recognition teams, leadership development teams. And we've also implemented new leadership evaluation methods where our raises are actually determined by our outcome goals. And many of our outcome goals are related to the Hcap surveys. So as a facility now, we are really looking closely and taking our Hcap surveys very seriously. So we utilize pretty much every function and every report we can from the NRC Picker website. They provide whoever you want privileges to a login and a password, and that allows you to see the reports that are related to your data. If you want to change slides for me, Shonda, I just put in a few examples of the reports that we can get. And again, this is going to be different with whatever vendor you choose. But they use the stoplight approach, of course, with the green, good, yellow, caution, and red stop. That you're going to see that you're going to get a rolling average, and then the first quarter is your most current quarter, and then the next 2 quarters are the 2 preceding quarters of data collection. You'll be able to compare yourself with the NRC average, and then also it gives you your N size, which is essentially, it's not your response rate, it's your response number. And then you can also see your percentile rank, which is how you rate nationally. The other thing that's nice about this report is that NRC Picker will designate the key drivers, which are areas that they have chosen to, that they think most impacts your overall measure, which is your overall question. So if you click on to any of these numbers, you can get another graph of the actual results. Because it is nice to know you could have an actual 0 score, and all of your responses could be usually instead of never. And it's just nice to know that, oh, we aren't quite as bad as we thought. You still need to work on that, obviously, but it gives you the actual responses. Because, again, you only get credit for the most excellent. The other thing you can do is you can go into any of these questions and you can find your actual true response rate. And so it's a pretty handy report when we use this a lot. The other report you can get, if Shonda would move on to the next one, is this is the value-based purchasing dashboard. And this is the one that compares your activity to your CMS benchmark. And now remember when I said we started out really, really high. We were in the 98th percentile nationally, and we almost couldn't get any higher. But this will tell you exactly where you stand. When it gets to the point where the Hcaps is attached to reimbursement, you will know where you're going to stand. And this is a really good report to show your staff. Well, any of these are very good reports to use. The other report, and if you want to, is called an experience dashboard. And in this case, we have, as you can see, several different surveys that we do. And the experience dashboard gives you all your surveys, 12-month rolling score at one glance. And it's kind of handy. So the other thing, and I guess I didn't put these on you can go back to the very first slide if you want now. Unless people want to look at that. The other thing with the NRC Picker is they do provide improvement plans, and I didn't get a copy of that, and I probably should have. But they help you use these. It's a tool to help you focus your resources and your energy on a specific problem or area or question. We have done improvement plans as groups with different departments. We've had like focus groups, and we've used this benefit of NRC Picker in several situations. They will provide suggestions for you, and like I said, with us being in the Studer group, we have found that many of their suggestions are actually well aligned with Studer. Now, I don't know how it is with other vendors, but with NRC Picker, this has been a very positive feature. There's also a report, and I didn't make a copy of this either, but it's a Trendline Report that plots your scores for the year. And it just plots your overall score and the Wood Recommends score. And but it does also include some of the key drivers, and it also will compare units. So if you, in our case, where we have 8 scores, it can compare those scores. As far as values, like I say, we use our Hcap surveys. We spend a lot of time on them. We interpret and take action, and we have tons of meetings. But there are issues that occur because of the Hcap survey. And one of them is the fact, and you're going to hear this from all the cause, we're very small. Your N size, or the number of surveys that you're scoring, is very low. And every single survey makes a huge impact on your final score. Also, we had some issues with our outpatient areas. PT, OT, and RT have numerous long-term patients that are never discharged or rarely discharged. And so for as busy as those departments are, they actually have very few surveys sent because they don't discharge very fast. So we have an issue sometimes with that. The other issue we run into is our patients kind of now with the universal survey or the universal membership are feeling like they're being surveyed to death. Even though NRC Picker says they only survey twice if no response, and then they aren't supposed to get another survey in 6 months, it just seems like they are coming more frequent. We also do discharge calls, and we encourage completing the surveys, and we try and talk up the surveys. But sometimes I feel like they do get a little tired of this, listening to us or the surveys. We have talked about this, in our action planning groups, and we realize we haven't probably promoted the surveys themselves like we should have. We've discussed this also with NRC Picker, and we are actually planning a We Are Listening campaign with hopes that it will help our response rates. Our response rates actually were in the 40% in that area, and they have been lately dwindling down into closer to 30%. So we're trying to take some action on that and help our patients understand why we're doing what we're doing, and that we're trying to improve, that we're trying to get to the excellence that we want. The other issue we run into is that we have a lot of elderly population, and they do have trouble with the surveys. And I think we have explained to some of the patients that if they want help, we will help them. They can come in, but that's difficult too. The multiple surveys that we have really can confuse the patients. That's another issue we ran into, and you won't see that if you're only promoting an inpatient survey. But with the multiple surveys that we've had, the patients get confused as to who they're actually surveying. And we've had comments, we kind of chuckle that lab does our personal cares, twice a day, and they do very well. So we just have it's unusual comments that you might get on the lab or x-ray survey. That's, they weren't thinking they were surveying lab or x-ray. So we are planning to change our cover letter. So we have a separate cover letter for all the different surveys. And then we are also looking at shortening the outpatient surveys. And again, that's something that we're working on with NRC Picker. And last but not least, the other issue we run into with Hcaps is staff. You don't have a quality department. You don't have the numbers of people to be on the committees, to be at the meetings. It's always the same group doing the same, doing all the different committees, and I'm sure you're going to hear that from the cause as you try and encourage the Hcaps. We have, and I think it's been very good. We have utilized staff more than, just the frontline staff, much more than we ever did in the past, and it's been very good because they don't understand what goes into all of this monitoring, and by involving them in the meetings and then the committees, it's been a very good experience for them. So basically, in spite of all the problems and issues that have come because of Hcaps, my answer still is yes, the cause should be encouraged to do Hcaps. And I think a big part of it is that you need to really push, you need to make it quality driven and do that before you worry about the reimbursement driven. Soon it's going to be reimbursement driven. We will have no choice. But that's how we started out as a PPS, was because we had to. And I think that made it not as valuable to us. We pushed paper, we did well, we have to do this, it's okay. I think if you can really push and make it quality driven, it took us 5 years to really kind of get a good system, even though our scores don't necessarily show it. We have a much greater enthusiasm, a much more focused facility on the quality, and I think it's good to get your practice surveys in before it does become mandatory and before it is reimbursement driven, because we have learned a lot. The North Dakota CAW network has been amazing, and it's really important for them to keep these CAWs focused and informed, and they have definitely been doing that. Because right now, more Hcaps, I think there's just so many initiatives, there's so many agencies after your data that it's just mind-boggling. And most CAWs look at Hcaps as just one more thing. And so I can understand their reluctance. So I think that they should, just tell them not to do as we did and accept those high scores and think that they will stay. We learned the hard way that excellence is a continuous process, and you have to keep at it. And again, like I said, the Hcaps kind of stands alone, kind of stands apart from the other data, but regardless, it is what you make it. The learning, the benefit is what you make it.
I completely agree, Julie, and I liked how you had said that satisfaction is a journey, and it sounds like your facility has really gone through quite the process here of making quality a part of your culture. I wish we had more time to dive into the loads of questions that I have for you regarding this journey that you've taken, but I really appreciate the perspective that you have provided, as well as the perspective that Shonda has offered us as well. We would love to continue this conversation next week on June 20th from 2 to 3 o'clock, where we'll be sharing details regarding the